Okay, it looks like we are live. Okay, good morning, everybody, or afternoon, evening. I'm Dr. Joshua Schiffman. I'm a pediatric oncologist at the University of Utah, and I spend an awful lot of my time helping to take care of patients with Li-Fraumeni syndrome. On this call, I've got two of my colleagues and three wonderful patients with Li-Fraumeni syndrome. So before we go in and get started, I'll just ask everyone to introduce themselves. So why don't we start with Wendy?
Hi, I'm Wendy Kohlmann. I'm one of the genetic counselors here at Huntsman, and I work with Dr. Schiffman and Dr. Luke Mays, one of our other Li-Fraumeni doctors, to help run our clinic and take care of these great families.
Jo?
My name is Jo Anson. I am lucky enough to be the research coordinator that works with Dr. Schiffman and Dr. Mace for all of our Li-Fraumeni syndrome research, from looking at pediatrics or children with Li-Fraumeni syndrome to our ctDNA study and our collaborations with so many other collaborators. So I get to run all of that.
Great. Jo and Wendy, thank you for joining us this morning. And of course, the real stars of the hour are our patients. And again, I'll remind the students watching this and anyone else who's lucky enough to view, is that the purpose of this is really to get to know some real live people with Li-Fraumeni syndrome and to understand that germline P53 mutation is much, much more than just a diagnosis in a textbook. And there are real people in real lives behind this syndrome. So I'll go through, I'll just ask each of you to introduce yourself in sort of just a 1 second, and then I'll go ahead and start with some questions, and we'll have a wonderful free-for-all. Like we were saying before, there'll be perhaps tears, laughter, and of course, coffee. So Jenn Perry, you're our first on the box on my screen. Just a few second introduction about yourself.
Yeah, hi everyone, I'm Jenn Perry, and I live in Massachusetts. I grew up here. I'm a patient who has LFS. I'm a mom of 2 children who have LFS, and my sister has LFS, one of them. And I'm fortunate enough to be president and co-founder of the Li-Fraumeni Syndrome Association. So thank you for having me.
Wonderful, thanks, Jenn. How about Trish?
Hello, everybody. My name is Trishia Shelley Stevens. I live in Washington State. My son and I both have Li-Fraumeni syndrome, and I am the founder and current treasurer of Living LFS.
Fantastic. Jenny.
Hi, everyone. My name's Jenny Gray. I live in Coeur d'Alene, Idaho, and I'm an LFS patient. My son also has LFS. He will be 4 in April. And we believe also my mother and maternal grandfather had LFS based on our cancer history. So happy to be here to talk to you guys about it today.
Fantastic. So Jenn, Trish, Jenny, welcome. We'll start off. I'll just ask a question and I'll say, tell us a bit about how you came to learn that you had Li-Fraumeni syndrome. What was the process leading up to the diagnosis like for you? Anyone can answer.
Okay, I'll start. So I was diagnosed with breast cancer when I was pregnant and 21 years old, and then was diagnosed 7 months later with the other side. When my son was 2, he was diagnosed with rhabdomyosarcoma. And we were at the hospital, and we had an amazing clinical nurse navigator who let me, because I'm kind of a research geek, read in the medical library. And I found at that time, and this was 1995. So I found at that time it was called SBLA syndrome. And I said, hey, I think we have this. And so we were tested back then. However, the testing was so new and our variant is really rare that they said it was inconclusive. So fast forward to 2008, and my mom was diagnosed with a stage 0 breast cancer, and they said, oh, you should have genetic testing. And I was like, oh, I already did. And they had the stuff faxed over from Children's, and they're like, oh no, this is clearly LFS. So we went 13 years without even knowing for sure. I mean, I always thought that that was what was happening. Interestingly enough, my parents are both negative for a TP53 mutation, so I'm a de novo mutation with that. My son did have the testing, and he was 17 at that time, he's 28 now, to confirm that he had the same germline. And then here our family tree is like so many branches of a genetic chaos. In 2019, my sister was getting ready to have a surgery, and they did a full panel of genetic testing beforehand and found that she had the CHEK2 mutation. And my dad actually has that, and Trey and I have now, we both have found that we have both a TP53 and a CHEK2 mutation. So so I went a long time without screening, without any of knowing that we actually had that. And so it was interesting. It was literally 13 years between actual diagnosis and blood tests.
And what were you thinking, Trish, during those intervening years? Just that there was so much cancer in your family, and how were you making sense of that?
Actually, there wasn't. That's
Okay.
what at that time, I mean, and even like with the CHEK2, like that's a much older, like they're not, so we didn't have the devastating, family history that a lot of families do have, where they're like, oh my gosh, what the heck is going on?
Mhm.
I suspected, like, and this was just, and maybe because I had read about SBLA syndrome, and because I was, like I said, 1995, like I didn't have Trey, even though he had a sarcoma, do a ton of CT follow-ups. We kind of, I mean, he got his follow-ups that way, but I always suspected that there had to be something
Right.
that was there. So it was really interesting. In fact, when Trey's had 4 more sarcomas since then, and I had, we went to MD Anderson for one of his, and I met with Dr. Strong, and she just said in 1995, that was like when you guys very first really were doing germline sequencing. And so because our variant just isn't a typical one, that's why they're like, we're not sure what this is.
Got it. Okay. Let's go to Jen or Jenny. Who would like to share their story of how they were diagnosed?
I'm happy to go next.
Okay.
So I was diagnosed with osteosarcoma at 31 while I was also pregnant with my son, like Trish. My mom had brain cancer. She was diagnosed at 34 in 1993, and my grandfather also had brain cancer. So prior to my diagnosis, my family had suspected there was something genetic. It was only brain cancer that we had, but both in the 30s. And so my parents had been asking questions for years, is brain cancer genetic? They saw doctors in like 5 different states. Various tumor boards reviewed my mom's case. Nothing ever was discussed or mentioned to my parents about it being genetic. We always suspected it was, but they always came back, oh, there's no evidence that brain cancer is genetic. So when I was diagnosed with osteosarcoma, in my mind, I was like, absolutely, there's something genetic here. So I started doing some research on my own, came across Li-Fraumeni Syndrome, and after reading about it, I totally thought that's what it is. And I mentioned it to my the doctor who did my amputation on my leg, and he'd seen quite a few osteosarcoma cases. He said, it's so rare, I don't think you have it, even with your family history, don't worry about that right now. So that was in February of 2017. And I did my amputation, carried my son until about 34 and a half weeks, and then we induced labor. And so from that time to from my diagnosis to my son's birth, I'm doing all this research, and in my mind, I knew at that point. And then after my son was born, I started high dose chemotherapy, and the oncologist I saw for that, he said, absolutely, we need to get you tested. I think you're right. I think you probably have Li-Fraumeni. And so came back that I did. And then soon after that, we had my son tested, and unfortunately he has it as well. So that's been the most devastating thing in this whole process, is that the right questions had been asked for a long time, you know, since the early 90s by my parents. The first genetic counselor we spoke to up here in Spokane, Washington, you know, my question was, how come that never came across any doctor's radar? And she said, well, typically with Li-Fraumeni, we see it more widespread. And in my family's case, it had just been 2 people really. And it had been the same type of cancer until my bone cancer diagnosis. And so the timing has been what's been the most heartbreaking thing. Granted, there would have been no saving me from it, but had we known, we could have done, you know, some in vitro fertilization and you know, pre-implantation testing if we wanted to have make sure that my son didn't have it. So that's kind of my quick and dirty story.
So Jenny and Trish, I'm sensing a common theme. I'm hearing a common theme really, is that you knew, and this is, we actually hear this a lot, you knew something was going on. You knew what you had, but you really had to advocate for yourself to convince the doctors to keep looking. Jenny, you in particular, because I know you've come to Huntsman and we see you, and I know the details of your story. One of the things that's always intrigued me the most, and I think is really an important lesson, and I'd like you to just spend a minute talking about it, is the fact of how active you were, and you were a runner, and your knee was hurting, and you were worried, and you actually even said to the doctors, hey, my knee is hurting. I have a family history of cancer. Should we be concerned? And everyone said, no, don't worry about it, as the tumor was growing in your leg. Can you talk a little bit more about that experience?
Yeah, kind of the story of how it came about. I've been an athlete my whole life. I grew up playing soccer and running track and basketball. And after college, I just kept running lots. So I had been running a lot prior to my knee starting to hurt. And it was like the summer of 2015 that it really started to bother me. And I went to the doctor and mentioned it. And she said, oh, I think it's just pes-anserine bursitis, you know, take this winter off from running, skiing, any of your activities. So I did, and it kind of seemed to help, but it didn't really get any better. And then that spring of 2016, you know, I started getting out hiking again, and it just got progressively worse throughout that summer. And so that was when I was really like, something is going on. This has been a year now. Went back to the doctor. She referred me to a physical therapist. They thought I had a torn meniscus. So I started physical therapy for that. And when I found out I was pregnant, that was when the pain really started to increase. It got to the point where it was very painful to walk. And my physical therapist and I kind of, you know, he's like, something else is going on. And to be honest, bone cancer never crossed my mind. You know, I never thought it was that. And maybe my physical therapist thought it did. Maybe it was that. He never said it, but he said, I think you have something else going on. So that's kind of what I went to an orthopedic surgeon, and he referred me for an MRI. And the MRI came back with a large, it was like softball sized tumor. Initially, they thought it was a giant cell tumor, which is typically benign. I had a bone biopsy done. The real quick, you know, work they did while I was still in the OR, they thought it was benign too, but then the full pathology report came back malignant. So basically, once I had that MRI and knew there was a tumor in there, I knew it was cancer. I just had a gut feeling, even though they initially thought it was benign. So there was, you know, there's a lot of missteps, I think, in the process. I think I overlooked it, but I just never thought bone cancer just never entered my mind, to be honest. So.
Well, it's interesting. We can get into this perhaps a little bit later, But one of the challenges of Li-Fraumeni syndrome, as Joe and Wendy know, is this is such a rare syndrome that people, even in the medical profession, we don't think of it automatically, right? And so that's why, and I know Wendy, especially like me, recognizes how important family history is, right? And so the fact, Jenny, that you did have two relatives, right, your mother and your mother's father with brain cancer at an early age, now these days we recognize, and it's not too long ago that this was going on for you, but now we recognize that as a red flag. And as all of we take any type of symptoms in Li-Fraumeni syndrome very seriously, right? And so at all, Jenny, because you come and see us in the clinic, we always say, if you have a pain and it doesn't go away in a few weeks, we need to take this seriously because of your family history, because we know that you have Li-Fraumeni syndrome and it's a risk. And so, Jenny, in your case, one of the things that's actually particularly tragic, but we're making the best of it, is you, like you said, you're an athlete. I know you were in a national forest, right? I mean, that was your job to run around the woods, if you will, and make sure everything is going okay, and checking on Smokey the bear and all that good stuff that goes on in national forest. But now that can't happen anymore because of this. And certainly, if we had known about the diagnosis, as you said, we would have never waited a year to check what was going on. And would that have changed the outcome? Who knows? How would that have affected your pregnancy? And again, we know, just because we know you so well here at Huntsman, that you were left with a really difficult choice, right? Because you were pregnant, you had to either choose to forego the standard chemotherapy for a little while to finish your pregnancy, or you would have lost Dylan, and that was a really difficult decision that you were made. And so there are a lot of ramifications, obviously, of having Li-Fraumeni syndrome and all of your lifestyle, from your job to family planning, etc. Okay. Let's turn to Jenn Perry. Your turn to tell us your story of how you were diagnosed with Li-Fraumeni syndrome.
Okay, yeah, a little bit of a journey, and I wish I could say I was the research extraordinaires that Trish and Jenny are, but I'm really not. I'm not interested in research generally. But I will tell you that in our case, we kind of thought our family just had some bad luck, and it seemed like throughout our family there were a ton of people that had cancer. My uncle, who I never got to meet, unfortunately, he died of leukemia when he was 26. My mother died in her early 40s from breast cancer. And, we've had other cancers throughout the family. We had never been asked for genetic testing for some time. I did not even get genetically tested till 2010. I had my first tumor in one of my breasts when I was 25. And, I had several removals, not mastectomies at that point, but I had gone back a few times for some removals. And then when I had my second child at 36, things just didn't seem to feel right after she was born. So they actually did some surveillance at that point, and I ended up they found some stuff in my left breast. So they had it removed and removed lymph nodes. But I ended up having a double mastectomy at that point. Again, I did not know I had LFS at this point. And, I'm very glad I did that. I had to go to 3 doctors before they would do a double mastectomy. At the time, a lot of doctors felt that, you shouldn't have to do that. That's the last resort. But, having watched my mom die at home from breast cancer left kind of a very indelible image in my mind. And I didn't want to take that chance. In my mind, if it ever came back in that second breast, I always felt like it was more aggressive after what my mom went through. And I really decided that I needed to find a doctor who was going to do a double mastectomy for me. So I found one doctor. I was very thankful that I had a OBGYN who was very aggressive. She was the one who actually said I should have had a double mastectomy about 10 years before, just with the family history she had seen. So I found a doctor who would do it, and I donated my breast to science, and it turns out I had a far more aggressive cancer in my right breast that they had not been able to pick up on any of the imaging prior. So they said it was pretty fortunate that I did that, or I would have been in really bad shape in about a year. So I still didn't find out until 2010, like I said, that I actually had LFS, and it was about 3 months before there was the NIH held that first conference for Li-Fraumeni syndrome patients, where they flew in a bunch of patients. And I was kind of overwhelmed, to be fair with you, because I had no idea, because they kept saying we didn't need genetic testing. It wasn't until my younger sister got breast cancer that they decided they'll do genetic testing. And they said, we'll test you for this LFS thing. It's very rare. We don't think at all your family has that. There's probably, it's just slim to none, but we're going to do it anyway. And sure enough, they did it. So we're assuming my mother had LFS. My father was tested. He did not, but obviously she died of breast cancer. She was actually one of the first, she was the first hospice patient in Massachusetts. So I don't know my grandparents on my mother's side. They actually lived till their 80s, in their mid 80s. They never had cancer that we know of. And I kind of what Josh said, which I think is super important, is family history. We don't even know, people were dying of things. We don't even know what they had. They wouldn't even discuss it. My grandparents and stuff like that. I only had one grandmother who would discuss it. She actually had bone cancer on my dad's side. So I'm a big proponent of that. I actually struggled. My husband did not want the children tested. He did not want my younger daughter in particular to feel that like her life was going to change if she found out she had LFS. And quite honestly, it was a very hard decision. I just went against what he said. I know that's really bad, but I did because I felt that I couldn't live with myself if one of my kids got cancer and they could have been surveillanced. And so we got them both tested and they both had LFS. So my younger daughter hasn't had cancer. My older daughter is experiencing some stuff now. She's going to have surgery in a few weeks. It looks like she might have a sarcoma on her arm. So she's had some breast issues too. So that might be a situation coming up shortly too. I have had, even after the mastectomy, the interesting thing is, even though I have LFS, they basically said I had no need for surveillance after after my double mastectomy, because you're kind of cured after that. But I have had to fight for that, advocate for myself for that. And I've had 2 other surgeries where there's been unknown types of tissue even after the mastectomy. They said at the point it wasn't cancer, but it wasn't normal tissue, so they removed it. So I've had a few surgeries of that. So clearly something's going on even after the double mastectomies. But thankfully, we're trying to stay on top of it. So that's kind of my situation.
So can you share with us a bit about what is it like living with LFS, with this genetic diagnosis, with understanding that you have such a high risk for cancer, that you've had cancer? Jen, you mentioned this family curse almost. That's something very common that we hear in terms of family members just before they
Everyone
were
was
diagnosed.
getting it.
Everyone was getting cancer. We just don't understand. But what is, everyone always worries, if I got a bump in my arm, it might be cancer. It's just a natural worry that people have. But when you have LFS, it's obviously 100 times more real. How do you live every day knowing that, and how has the diagnosis impacted your life?
That's a tough question. The diagnosis certainly has impacted my life, and kind of what Jenny was talking about, and I'm sure Trish feels the same way. Getting the diagnosis after you've already had your children, there is a level of guilt. I'm not going to lie. You have to think about that, a lot, but, here I feel like I gave my 2 kids LFS and they're going to have to live with it the rest of their lives. So there's a little bit of that. And I try not to think about it, because it's not like you did that on purposely and knowingly. And I didn't even know I had LFS at the time. But you do feel like that shoe's going to drop. You feel like the shoe's going to drop. You're waiting for that shoe to drop. But one thing I've tried to do is just fill my life with positive things that I can do. I remember telling me, they said, I love to horseback ride and I show jump competitively. And they said I'd never be able to ride again after my surgeries and the reconstruction and stuff. And I said, no, that's not an option. I'm going to ride. So I think the big thing for me is not to be cheesy about it, but really living your life every day and trying to thrive with it. So if I focus on all the negative that can happen, life is too short for that. I just want to live my life as full as I can. You can see my horse behind me. I love to ride. So I try to fill my life with those types of things and, be there for my kids, because this is a journey for them too. And, they've got a ton of health issues too. Thankfully, my younger daughter, not so much now, but she lives with the guilt of not having cancer right now. And it actually affected her in a big way. For about 2 years. She wouldn't even involve herself with other kids with LFS. She just couldn't even hear the word cancer anymore. So it affects you. It really does affect you. But having people around you, which, you know, when you hear about these support groups and stuff, it's very important to know that you have people now that you know. Like when I was diagnosed in 2010, and I'm sure Trish going back all those years as well, she probably didn't know anyone else that had LFS either. So there was a very small group of people. And now, you know, there's a lot more people. So when you're having procedures or when you're having things done, you at least know a few people that you feel that you can trust and go to and confide in, or at least talk to, hopefully. So it's important.
Someone else want to talk about how do you deal with this constant worry about cancer? And Trish, I know you've taken particularly a very positive attitude.
Yeah, well, humor is a big thing. That's what I just turned 50, which is 874 in mutant years. But yeah, so levity, humor. I mean, it's a heavy diagnosis. You know, my son has been cancering pretty nonstop since 2014, and he just was diagnosed with metastatic leiomyosarcoma. And I was just diagnosed with chronic lymphocytic leukemia. So it's a heavy diagnosis. And for me personally, I always think that whatever crap you have going on in your life, like, it's okay to have down days, it's okay to have that, but it's super important that you keep moving forward. And for me, a big component of that is being able to give back. We've always had a ton of support and a lot of help. And so, you know, we have a very active Facebook group with a support system with Living LFS. And, you know, we did family camp, and we make a huge it a huge priority to connect people with each other, because it is so isolating. And then on a personal note, you know, 3 years ago, we started a screen printing company that makes hilarious cancer t-shirts, and then we work with patients and nonprofits to do online t-shirt fundraising. And like last year, in 2020, we were able to send out over $55,000 to patients and nonprofits through those efforts. You know, we give 10% of our retail back. So for me, finding that kind of purpose, and I think, you know, I'm sure Jenn Perry feels this way with the LFSA, and just any type of advocacy work that we can do, because it is heavy, you know. But yeah, laughter is good. Very dark humor. If you go on Snarky Cancer, it's very, very snarky.
Trish, tell us the website so people watch it.
It's www.snarkycancer.com. And like, you know, my signature line on my emails, in hope and humor. You know, I think that's the things that you have to do. It's okay to cry. It's okay to be bummed out, because this is heavy, but you have to find something that makes it so that you put one foot in front of the other every day. And so that's what helps. But, you know, going back to that, with a new diagnosis, with what's going on with cancer, being a business owner, it's so challenging. It's so challenging. And to juggle the doctor's appointments and the follow-up and the financial implications, I mean, it's challenging. So I feel like this, you know, you letting us tell our stories this way, so that people know that they're not alone. The medical professionals that are dealing with us kind of see us as whole people, instead of just our disease, because we're so much more than that. Absolutely. I mean, we're really pretty awesome.
I think so. And, you know, it's hard, obviously, to fathom having had one cancer diagnosis, then having had 2 or 3 cancer diagnoses yourself, but then having another family member with 2, 3, 4 diagnoses, and then you, Trish, going through, or 5, and having them at the same time, right? The way that just upends your life, it's almost unimaginable. Now, but it's true and it's real, and you get through it. Jenny, tell us a little bit about how do you deal with this, and how has this kind of affected your thinking and just your whole life and family?
Yeah, it's, to second what Jen and Trish said, it is super, super heavy diagnosis. It's heartbreaking. And for me, it's, I'm 3.5 years into knowing I have LFS. So it's still pretty fresh, and it's a job every day to really emotionally keep it together. I feel like the last year and a half, I've really been able to, there's been like maybe a couple days thrown in there where I didn't think about it. But the first, the first year and a half while I was dealing with amputation, cancer treatment, being a new mom, figuring out how to walk again, it was a constant, it was always on my mind. And it took me to a really, really dark place. And I tried my best not to let it, swallow me, but it's hard. So I think, for me, it's been really helpful to get some normalcy back in my life. Like once I was able to go back to work after treatment ended, that really helped me. Regaining some of my physical activities has tremendously helped, getting back to hiking. So a lot of that's come with getting better mobility with prosthetics, which that in itself is another fight, dealing with that. But that's helped tremendously. And then just like Jen and Trish said, trying to find joy in the everyday things, watching my son grow, watching him learn new things. It's really hard to, like Jen was saying, you have guilt about feeling like you gave this to your children. Of course, unknowingly, we didn't do it on purpose, but there's this heavy, heavy ache in your heart knowing that your child is going to have to face this at some point. I mean, the screenings themselves, thank goodness we can do them, but that in itself is a anxiety ridden process. Dylan's not really old enough to understand it yet, and he's done great with it so far, but as he gets older, trying to figure out how to explain that to him. And then also having the feeling of, it's not a matter of if, but when. That's what it feels like with LFS. Like we've all had a cancer or several at this point, and it doesn't feel like the ride's over. It's like, okay, made it through that one. Is there another one coming? And you're always kind of anticipating it and trying to figure out how to balance not letting those feelings overwhelm your life. It's really hard.
Yeah. Have you found a good way to achieve that balance, or is it a constant struggle?
It's a struggle. I mean, I think just regaining some of the normalcy, like I said, that's been the biggest help for me. And then connecting to other people in the LFS community, that's been awesome. I think that's been the most helpful thing, just knowing that there's other people out there dealing with it, sharing our stories, seeing stories of hope too, how people have overcome it, how people are living into their 80s with LFS. That's refreshing to see, because it is an isolating thing, like Jen and Trish said. And when you have only your family to compare it to, and in my case, both my mom and my grandpa died at age 53. So it's scary. That number is in my mind. But then when I hear stories of other families where they have members living into their 70s and 80s, it gives me hope. Granted, there's different variants of our mutation, and that potentially affects lifespan, but that's been really helpful to hear other people's stories.
Because go ahead, Jen, please.
And I was just going to say, and I know we're speaking to future doctors, which I think is awesome, and I appreciate them listening. We just had our virtual symposium last fall, and I gave a speech, and I was fortunate enough to be able to do that. But I think for the med students out there, just remember to walk in our shoes. So when we're sitting in your office, seriously, very vulnerable. Some of us, are going to be very open about our stories. Some of us are not. Some of us are great researchers like Trish. I am not. Everyone is very different. But remember to walk in our shoes, and we're very vulnerable. Whether you're giving us a diagnosis, whether we're living with a diagnosis, we're hoping that you're going to look at us and see the things that might be unsaid or said. And, I think there was one line that I said that is really important to me is, people don't care how much you know, no matter how smart you are, until we know you care. And I think that is the biggest thing. And, understanding it's just not one thing. It's not like we're getting an injury and it's healed and we're moving on. You know, like Jenny said, it's something that it's not about if, it always is about when. So just know that as you're walking in our shoes, as you're treating us, it's a very different type, I think, of a diagnosis. It is very rare. You know, these guys have mutations. I have a deletion, and it affects everybody in a very different way. And so I don't know, just keep that in mind as a med student, that everyone acts very differently to it. And I don't think, I'm sure Trisha's in the same boat. You know, there isn't a day I don't go by that I'm speaking with a patient. And, you know, we have 9 international chapters right now. And the one word that everyone says, even in Brazil with the most patients, is everyone feels very isolated. And you wouldn't think that, considering, I know it's rare, but it's as people get tested, and, you know, we're really working, I think, towards getting more of that happening, getting insurance to cover things. But it is very isolating and people feel alone. So just know when we come into your office, how we're kind of feeling, and just remember that a little bit. And I know you will.
Yeah.
You got Dr. Josh helping you out with that, but it's important
Jen,
to.
this is perfect segue. So this is exactly what I want to talk about, because we do have a lot of medical students and future doctors and young doctors who are watching this. I want to ask each of you, when you do interact with the team that's taking care of you, the healthcare team, whether it's a doctor like me, a genetic counselor like Wendy, a clinical study coordinator like Jo, what are things that you've heard and experienced that have been helpful and that really have given you strength and comfort and hope? And then on the flip side, because I know it's out there, what are things that you've heard that you, oh no, you didn't just say that, did you? Things that just these future doctors should remember to never, ever say or do to their patients. Because this is really an opportunity to teach future physicians. And it's not just about caring for Li-Fraumeni syndrome, a very rare condition with P53 mutation, but even when you were diagnosed with the cancer and all of your experiences in the medical community, Jen, we've heard you say, put yourself in the patient's shoes, but can you give some sort of concrete examples? Again, things that went well and maybe things that didn't go so well.
I think one thing that's been really hard, and granted, I know this is a rare mutation, but to hear that over and over again from doctors, like when I was first diagnosed up here, a lot of them had never heard of Li-Fraumeni syndrome. So I was the one educating them about it.
Mm-hmm.
I was bringing papers, I was sending emails saying, hey, this is what I found in my research. But to continually hear, oh, it's so rare, and kind of be dismissive about it, that's been really maddening. And, I know in med school, doctors are kind of taught, when you hear hoofbeats, think horse, not zebra.
Right.
But in our case, we're kind of unicorns. And I think it's like, if you as a doctor are willing to take the extra time to research a patient's concerns, that is, like, it speaks volumes, even though it might be something that's totally, you're off on some crazy tangent, but for us, it could make a huge difference. And, other people with rare genetic conditions. I think one thing that's been really refreshing, coming down to see you, Dr. Schiffman, in Utah, and working with Jenny, you guys see this more often. You deal with a lot of LFS patients, and coming to see you guys has brought a lot, it's eased my anxiety a lot, because you've been able to answer so many questions that doctors up here haven't been able to answer for me. You've been able to put a lot of my anxiety to rest by just your knowledge base that you have. So, if speaking to the students that are going to be listening to this, if you have a patient in the future that does have something rare, really work with helping them find a community, a medical community that is more specialized, to connect them to that resource and open up opportunities for learning more and seeing specialists who just have a lot more knowledge about it. That's been helpful.
And Jenny, are there specific things that our team here has said or done that's been most helpful for you? Or I should ask, to be fair, things we've said that maybe haven't been so useful?
I think just with the screening that we go through, it's very extensive, and you guys have really put at ease the fact that we're being we're being looked at so closely so often, you are going to see weird little things pop up that really probably everybody has, but they don't know because they're not being screened. They're not getting MRIs multiple times a year. That has helped me a lot because up here, when I was going through treatment, especially any little weird thing I had, they'd do an MRI, but then they wouldn't really know what it was. And so it sent us down this spiral multiple times of like, oh, there's this weird thing on our gallbladder. What is it? And to be safe, they always were like, well, under normal circumstances, we wouldn't really worry about it. But because of Li-Fraumeni, we want to take it out. So it led to multiple surgeries that probably weren't necessary. In both cases that I'm thinking of, I had a weird gallbladder thing and a weird, like a little lump in my breast. They ended up being nothing. I'm glad they're out though. But it's nice to have, the reassurance that, yeah, you're probably going to have a hemangioma on your liver or some little thing pop up that most people have that we just wouldn't see normally because you're not being in the MRI tube multiple times a year.
Jen and thank you, Jenny, for sharing that. Jen and Trish, any other comments in terms of interactions you've had with doctors, things or attitudes or way people have said or not said information and helped to take care of you?
I have a couple. So
go for it, Trish. This is your chance to unload.
This is it. Well, for one thing, I do want to emphasize that mental health needs to be part of this. A good counselor, a good social worker, connecting people with resources. When you're putting together a team, I mean, you need a team. And my personal counselor is always like, the people with LFS, it's never ending. Like we've all said, waiting for the shoe to drop. So our legitimate PTSD there's not an end date for it. So making sure that when you're setting up a medical team for somebody or when you're working with a group that mental health is part of it. But when I was pregnant, 21, I lived in a small town in Montana. We went to University of Washington for my mastectomy because they were like, oh, you're pregnant, can throw you into labor. We want some place with a NICU. And I remember this distinctly. So they're wheeling me back for surgery. And the med student legitimately looks at me fascinated and touches my stomach. It was completely, so I felt like a lab rat, right? So I remember that. And then I had a doctor once that I was about 25. I had gone to the doctor who legitimately asked me, are you sure you had breast cancer? And I looked down my shirt, pretty sure it's gone. So that was not good. And when Trey was set up with an oncologist here, and he had fibrous dysplasia, and he had FNH in his liver, like you were saying, all these other things that the radiologists here were like, oh, he's got metastasis, and we go to OHSU in Portland now, and they were like, oh no, that doesn't even look like metastasis, that's FNH. And his oncologist here at first, now of course, 4 sarcomas later, was like, oh, that screening is overkill. And I'm like, pretty sure it's not. so that was tough. That's why, I had a low-grade sarcoma in my arm, but that Trey's oncologist, Dr. Laura Davis in Portland, is super LFS conscientious. I am always so appreciative, and she sees me, even though at that time I'd never had a sarcoma. But things like when Trey was doing his osteo treatment and the MAP protocol did not work, and so they switched to high dose IFOS, and MD Anderson recommended 6 doses, but she was like, the chance of AML after having 3 doses of MAP and then another 6 of IFOS, and he's already had all this chemo from when he was 2, let's only do 4. And those are things that I love about her, is that she's always thinking about how to balance treating the cancer we have, right? We call it fighting the shark closest to the boat, but still being very, very cognizant of the implications of such genotoxic treatments. And even like this metastatic diagnosis, which is freaking devastating, instead of starting with hardcore chemo, she advocated like crazy, and he is doing a combo that's really never been used in sarcoma, where she's doing Keytruda and Lynparza, which is technically for metastatic breast cancer, but because Trey's tumor had so many genomic alterations, she's like, listen, my scientific mind. So thinking outside the box for us, because we don't really fit in the box. And they're just very, very compassionate too. They're very responsive on my chart. We're really, really thankful for them. But like Jenny, I mean, I met the CLL specialist yesterday, and he's like, okay, you probably know more about LFS than I do, just because like CLL is not a common LFS cancer. And so that always is kind of hard. I remember being in a conference once, and the genetic counselor was like, saw me, and she's like, oh my gosh, I'm so sad you're here, because I'm probably going to mess up the LFS part because I'm a BRCA specialist. It was like a breast cancer symposium. So they actually ended up asking me questions. Sometimes we're more educated than our healthcare professionals, and that requires a lot of patience and a lot of emotional energy that we have to expend, that sometimes we don't have to expend. So
it sounds like what I'm hearing from Jenny and Trish, from both of you, that really understanding your patient and doing your homework ahead of time makes a tremendous difference.
yes.
And that confidence married with compassion is so key. Jen, how about you? I know you've had many experiences, some good, some not so good, with the medical community.
Absolutely.
Here's your chance to unload and share and teach.
All right, you gotta keep it top secret though. You gotta keep it top secret, Dr. Josh, though. You know, I think when I think back about the things, some of the simple things can be some of the most negative in terms of affecting. I'll give you a couple examples. I remember when they didn't want to actually genetically test us. They felt like, you know, we really didn't need to and such, but, you know, then it came back. And when we got asked to go down there, like I said, I'd only known I had LFS for about 3 months when we went to this conference. I didn't even know what it was about, but it was about LFS, and all these doctors were around the world and specializing in it. And I remember one doctor in particular, my doctor was like, see, you know, you're fine. You know, there are people much worse than you, you know, don't worry about it. And was very dismissive of me and my family. And I think the one thing I would love every, you know, doctor to know, just because someone is not necessarily dying at that moment, you know, you don't know everybody's story. So be very careful in my book to judge people, and because you don't know everyone's whole story. You're not living their life. So I think it's very important when you talk about being empathetic. I always tell people in my world, like, you can't judge tragedy. It's not about how many people have died in their family. It's not, you know, about who's had the most cancers. It's not a competition. So I just be very thoughtful about that. There are a lot of small things I can tell you. My daughter's pediatrician, my younger daughter's pediatrician, I walked in and she had just had back surgery, and she had some serious pain going on for some time, more than probably I should have let go on, and was trying to tell the pediatrician, you know, we're going to take her to Boston probably. And she's like, I don't know what you're talking about, this LFS thing. I've never heard of it. Now, I just happened to be just randomly wearing my jacket for my association. It just happened to say LFS Association. I said, well, see, it's embroidered on my jacket. It does exist. Let me take you to the website. She's like, no, I've never heard of it. I wasn't trained with it. LFS doesn't exist. I'm like sitting here dumbfounded. I'm like, listen, let me just take you so I can show you that this is a genetic syndrome. And I got to be very careful about the other x-rays. You know, she just had surgery. You know, we have to be very thoughtful about, I don't mind having them. And she like kept cutting me off, and she's like, you don't understand. Like, it doesn't exist. I literally finally got up, walked out of the office. I just couldn't believe that this woman wouldn't even like look it up. I was just dumbfounded. And my daughter's like, oh, wow. She's like, look, I don't normally get into this medical piece, but this is ridiculous. Like, I don't want to see this doctor anymore. So, you know, kind of at least before you doubt some of what your patients are saying, particularly those like Jenny and Trish, who do a great job with research. I don't, but I know enough to be dangerous. You know, you got to have a little bit of, at least take the time if your patients are saying and talking about something. Not everyone's a hypochondriac, not that you feel that way, but it's important to really pay attention to some of these details, especially with those with genetic syndromes that really could make a big difference. And then be thoughtful. I'll give you a simple example. It's kind of funny. You know, I have my double mastectomy, and who's there when I wake up to be my nurse, but a male nurse. Now look, I've already had kids. It's not that haven't been exposed before or anything like that, but a male nurse after a double mastectomy, I thought was a little bit not so thoughtful. And then the whole team would come in the morning, and one morning I was having a sponge bath and I'm completely naked, right? And this young doctor walks in, she's like, yep, we got the whole plastic surgeon team here and blah, blah, blah. And I'm sitting there with my sister. I'm like, look, I just need a minute. Like, I can't believe you guys didn't knock. She goes, no, well, we're the team. And I'm like, that's great. But, and it was one of the first times I actually ever lost it. And I don't know why, but I never advocate for myself, but I completely lost it at that point. I'm like, you need to leave my room like right now. Like, I just couldn't even contain it anymore. And she was like stunned, like, why are you asking me to leave this room? I'm like, because I'd like a little privacy, be just a little thoughtful about the little things in life that make a really big difference for a patient. So I think that was a lesson for me. And I can give you a couple more examples about the little things in life with that. But, you know, paying attention to the small things. It's not always about the big things like diagnoses and surgeries. It's just the thoughtfulness of the little things that happen all the time, the worries, the phone calls. If you could just, you know, sometimes we just need you to be there for us. I know with Josh, I do that all the time. I'll text him. Sometimes you just need a little bit of reassurance from people, like everything's okay, or, you know, this looks like it could be, you know, whatever, you're fine, and helping others, you know, get some answers. So I think thoughtfulness goes a long way in terms of that. But, you know, I've had some great experiences. The woman who did my double mastectomy, she was my surgeon. She was the one out of several doctors that actually would do the double mastectomy for me. I was so grateful, but I remember her when I was sitting down, I was on the gurney, obviously in the operating room, and there was a big delay. We were waiting for the anesthesiologist, and I'm obviously stressed out and a little bit tense. And I remember her just taking the time. She came in early and she just rubbed my arm, and she just stayed there the entire time. And she was talking to me, and she was so kind and so thoughtful. And that makes a big difference. It's those little things and understanding and walking in those shoes that just left such an impression on me. And I didn't know she ended up having melanoma at the time. And so she literally was walking in my shoes. I didn't know she had cancer at the time, and she passed away, unfortunately, a few years later. She was probably one of the best doctors I've ever had. She was incredible. So I think those things, there's so many positive things I could mention and negative. Be curious, be inquisitive, don't be afraid to ask and do some research. And assume innocence with your patients. Always, you know, assume that their concerns are real and that they, you know, they may lead to nothing, but you know what, in our case with genetic syndromes, it could lead to some big things. So,
you know, Jen, in med school, one of the attending physicians taught me, he said, don't be afraid to touch your patient. Right? It's okay to put your hand on the patient. You're not going to get sued, right? You weren't going to sue that surgeon for rubbing your arm. That
that got me through it. It was the most incredible thing ever. And you know, it was a simple gesture, because you know, we could hear a patient in a lot of trouble in another room, and I was starting to freak out. And she just sat there for 20 minutes just rubbing my arm. And here she was going to be doing like a 10-hour surgery, and she didn't, just sat there, and it made, I'll never forget that ever.
And I would argue just rubbing your arm is and holding your patient's hand, that's just as important medicine as everything else we do. So
it's probably more than anything, honestly.
So two more topics, and then I'll let everyone get on with their day. I also want to give Wendy and Jo an opportunity to ask any questions or bring up any points from their perspective. But the first is, tell me just a little bit about surveillance. We know in Li-Fraumeni syndrome, this is so important, looking for early tumors, right? As soon as we make the diagnosis, even starting in infancy, we're on the lookout, because we know if we find tumors early, hopefully we can improve outcome and really help quality of life. What are your experiences with surveillance, the anxiety, the relief? Talk a little bit about that.
Okay, I'll go first. We're fighting really hard to get surveillance and get it covered. My insurance, even though I have very good insurance, I have 2 insurances actually, just because of all the, at one point I had 11 surgeries in 10 years, but I have to fight for surveillance, and I go to a pretty great hospital, I would think, in the Northeast. I just got a whole body MRI. I hadn't had one for 5 years. I have to advocate for that. And quite honestly, it's a challenge. And it's very unaffordable for a lot of people to get whole body MRIs. If it's not covered, it's thousands of dollars. And I was lucky enough when I first found out that I had LFS, I was in a pilot for 3 years. So I had surveillance for 3 years in a row. And then it was several years again. So again, I just had one, and it's been 5 years. And it's a shame because you miss things. And although you're getting other stuff like, colonoscopies and such, there's so many things that are missed. And that's the case with my older daughter right now. And I'm very grateful that, with this last surveillance that they hadn't found anything. And like Jenny said, there are some innocuous things that sometimes they find. I've had things on my kidneys and things like that removed as well. And it needs to happen. In our case, particularly with this genetic syndrome, it happens very quickly for a lot of people. Things progress very quickly. It's so random. It's not like you're dealing with one cancer. You're dealing with, 9 main cancers. It can be all over your body and you have no idea. So when you're talking about surveillance, in our case in particular, I mean, it's absolutely critical. I know some people don't believe that, which is really tough. And I mean, even doctors in the LFS world, not everyone is convinced that whole body MRIs are necessary, but it's not just whole body MRIs. It has to be in a package with other things like the colonoscopies, the dermatology appointments, all those types of things. Surveillance is more than just whole body MRI. It's the whole package of the different types of things you have to have. And are they pain in the butt? Absolutely. Do I get sick of going to the doctor? I love you all. But when you go multiple times a year, every year in your life, sometimes I've actually just canceled appointments. I'm like, I just can't do it anymore. Like, you just got to take a break, like a timeout, and that's it. But it is important to have surveillance. I wouldn't be alive today probably without surveillance. I feel if my mother had surveillance and we knew she had LFS, she would be alive today. So her treatment actually killed her, not the cancer. So unfortunately, we know that for a fact. My dad just didn't choose to tell her. He didn't want her to know that before she died. So it's important.
Thanks for sharing that. Trish and Jenny, any comments on surveillance?
Yes, surveillance is a big pain, but it's necessary. But they're, in the United States, I remember in Toronto, Dr. Malkin standing up and apologizing to the doctors and the patients in the US for all the denied MRIs. And so I think that that's another thing that medical students need to realize is not only do we have the fear of cancer, but we also have the insurance that we're fighting. We also have all of the devastating financial effects that all encompasses living with such a broad spectrum of cancers that you can have in such a heavy surveillance schedule. We just had in our Facebook support group that somebody just, that's newly diagnosed, that's like, I just don't think it's fair that we have to be in debt for the rest of our lives for something that we can't control. I mean, I always say I'm on a permanent payment plan with several hospitals. So that is, and like for me, I'm super claustrophobic. Like I have to get put under to do MRIs, and I don't want to do it this year. I don't. I mean, and it's because it's a lot, and it's the travel. Like it's a 3.5 hour drive for us because it's worth it to go to a major cancer center. We call it scanxiety, and it's a real thing. It's before the scans and then waiting too for the results. So I'm a huge fan of my chart releases because for me, like waiting for results, and when you used to have to like wait for a doctor to call you was, I was always calling and being like, can I come pick up my results? Can you fax those to me? Right. So I want to know right away. So that I'm a huge fan of my charts. But if you are at a smaller hospital, if something, you know, especially a family that deals with as much as we do, you know, a text, a phone call, an email that says what's going on. So especially it never fails that you have to wait over the weekend, right? Because our minds will go to those places. They just will. So it's super important. I mean, I understand that, and like my CLL was caught because I have blood work all the time, and I could watch my lymphocyte count getting higher and higher and higher. So I caught it super early because of surveillance. The other thing I do want to mention though is, so my son's last, whether it's a recurrence or another primary, because it's in a radiation tumor bed. He had a scan in March, and the end of June, he started having pain. And this is the other thing that I think is that listening to your patients when they come to you and say, I have pain that doesn't go away after 2 weeks, and knowing in people like us to do the scans. You know, like I said, he's got an amazing medical team that of course listened to that and got him in right away. But even between a yearly MRI, I mean, it was, you know, 4 months, and he already had a substantial tumor. So
Jenny, thank you, Trish, for sharing all of those very important points. Jenny, talk a little bit about your experience with surveillance. And Trish, what you mentioned, by the way, this idea of financial trouble, we even have a term for it. We call it financial toxicity, right? So you get toxicity from drugs, but you also get financial toxicity from the treatments. But Jenny, talk a little bit about your experience. And I happen to know personally that you have to get on a plane and travel for hours and days to actually get the scans.
Yeah. You know, I'll just second what Jen and Trish said. It's a necessary evil. And I hate to use the word evil because I'm so grateful that we're being surveilled, but it does bring a lot of anxiety and financial burden. We traveled down to Utah for my whole body MRI and my son's whole body MRI, because there's really no place close by up here that has a machine capable of doing it. We could do it here, but it would take like 7 hours. And you know, the rapid whole body machine down in Utah, it's still a 3-hour procedure for me. So you have a lot of time to think while you're in the MRI tube. And then like Trish said, you got to wait for results. And so a lot of anxiety, but I'm so grateful to have it. And, you know, it kind of it's similar to what my husband and I felt after we got my genetic test results. Do we test our son or not? We're either going to get the biggest relief of our life knowing he doesn't have it, or if he does have it, we will know and we will be able to watch him very closely for the rest of his life. So unfortunately, you know, he had it, but now we're able to do the surveillance with him from basically infancy. He had his first whole body MRI at 1.5 years. It's stressful. He has to be sedated for it because he can't hold still. You know, he's a little kid. So I think for me, the biggest anxiety is just my son having to go through it, that process of being sedated. But I'm very grateful that we're watched so closely. The financial burden, I don't know, you just kind of have to try to budget for it, but it's challenging. I think for the med students, if you ever have somebody in our shoes or dealing with some other rare case where they need to be watched very closely, really advocate for them and help them in the battle with the insurance companies, because it will happen. We deal with it multiple times a year, battling for breast MRIs or the whole body MRIs, whatever it may be. And if you can be an advocate for us and help expedite appeals and whatever it may be, that is really, really beneficial. I've been grateful that my doctors, both here and in Utah, have helped with that, because it's a couple times a year I'm fighting my insurance about something. So
As a physician, we have to advocate not just for your health, but for your wallets too, right? And to make sure that
Yeah.
this diagnosis is not going to leave you financially devastated, right? Because there's so many other aspects of this that we're dealing with. One point, and I'm going to go to the next question. Trish, you mentioned getting the scan results back on my chart. And Jenny, you and I, we just saw you a few weeks ago in the clinic, and we had a really interesting conversation about this. So this is a wonderful, wonderful thing that now the patients can get the results almost immediately. Sometimes as soon as the radiologist presses, final on the report, it goes to you. It also is very challenging for the oncologist because we don't always know that's going through. And absolutely, we try. Now, Wendy and Joe know I may not be as quick as I want to be or as I think I am, but we try to get the results back to our patients as soon as we see them. But sometimes this means that the patients are getting the results even before the ordering doctor has seen them and knows what they are, whether they're good or bad. And so this represents a new way of practicing medicine, and it's here to stay. It's a good thing, but we are still learning how to adjust to this in the medical community. So I think that's kind of a stay tuned type of area. But again, it's the way things are, and absolutely we want to relieve whatever anxiety. We don't want to unintentionally cause more anxiety. So we're working as a medical community to figure that out. Okay, so the last question for me for today is, and this is a shameless plug because we do a lot of research on Li-Fraumeni syndrome, all aspects, from elephants to circulating tumor DNA, you name it. Jenny, you've been in our lab and visited and seen what we've done, our academic lab. Jen Perry, you've actually come with LFSA. And Trish, I don't know if you've seen our research, but maybe you've heard about it. But talk to the students a bit about what does research mean, clinical research, basic science, translational research. What does this mean to you as a patient of LFS? And talk about the hope or the frustration that this type of research into your diagnosis, your syndrome, provides to you and your families.
I'll start. It's a tremendous amount of hope, especially after I got to tour your lab a couple years ago. In my case, the treatment I went through for osteosarcoma, it's the same treatment that's been around for like 40 years. Mm-hmm. And the fact that it hasn't changed in so long, it's a really, really high dose, very toxic treatment. The research that's being done at Huntsman and across the country gives me hope that there will at least be better treatment options available to people that aren't so toxic and result in further cancers or other, heart problems, whatever it may be. But also hopeful that there's, we've got this amazing research going on at the genetic level, and it gives me hope that there's maybe a cure for this, or at least something on the horizon that will be a therapeutic that could be a replacement for the broken gene that we have. And so if that's in my lifetime, I don't know, but it gives me hope that there will be something within my son's lifetime that will make this an easier battle for him. And I hope that he never has to go through what I went through, what my mom went through, what my grandfather went through. The frustrations, I think, and I'm maybe naive here, but it's a slow process. And I'm hopeful that what happened this year with COVID and cutting out some of the red tape at the FDA level will continue with cancer research, and that they'll kind of expedite some of these trials that really people are dying waiting for. So that's my hope, that things will be expedited a bit. But it's really cool to see what's going on, and at Huntsman specifically, but across the country as well. It gives me a lot of hope.
Great. Thank you, Jenny. Jen or Trish, any comments on medical research, clinical trials, and how that impacts your life as patients with Li-Fraumeni syndrome?
I remember being struck profoundly at the first LFSA in-person symposium, listening to research. It's really easy to get jaded because it takes so long, you know, and you think, gosh, you know, there's been all these diseases that they've come up with something, maybe not to cure, but to make it, like AIDS, for example, like a livable chronic disease. And it's easy to get jaded and think, why can't they do that with cancer? But I just remember being really profoundly struck listening to the researchers and how much passion that they have, like that they legitimately care. When we did our first little mutant meetup as Living LFS in Portland, and we had teleconferenced one of the adrenal specialists from St. Jude's, and it was that same, just hearing the passion that they have. These people really are working on our behalf. And it's been exciting to see, just even in the past few years, how much progress there has been made with the immunotherapies and PARP inhibitors and targeted therapies that, and Ann Raymer, who I think that you know that she's such a huge advocate for compassionate use and for more of, instead of monogamous, you know, therapies, that something that is used traditionally for breast cancer, because now they're looking more at a genomic expression, using it across the board. So it's been, so I have the same frustration of how long it takes. The other thing that I see is like all the different places that are doing the same research. And that's always a frustration for me as a patient. I'm like, why don't you all just pull this information together? Because just like circulating tumor DNA, like Portland's doing it, Huntsman's doing it, there's the Edison, there's City of Hope, there's all these places. So can that somehow, like the data at least, so that we have that? I mean, it would be phenomenal for us to be able to do that versus have to get into an MRI machine, unless of course, you know, there's something symptomatic that we have to do. So I think that that's one of the frustrations, but I'm thankful, and I hope that someday I get to come tour your lab. But yeah, I'm super thankful, and I am hopeful that not only on the LFS part, but my hope is that someday we get to treat cancer as a chronic disease. I think that there are so many biological aspects to cancer that I don't think there's going to be one cure-all, but that's my hope, is that those of, you know, when you have a son who has metastatic and he's 28 years old and he's done nothing for the past 7 years but have to deal with cancer, it gives me hope that he'll find the treatment that gives him stability so that he can go on to live a life outside of a hospital. So
we agree. We agree with you, Trish. And you are always welcome to visit our lab and see what we're doing, and hopefully
fantastic.
give you and your son more hope. Jen, how about you? You've been around LFS researchers for many years now.
Yeah.
What are your thoughts on research?
You know, it's funny, people always ask me, why do I stay involved in an organization? As Trish and possibly Jenny know, it's a lot of volunteer hours. It's a lot of your time. And I always say the same thing because it's how I feel and why I'm involved in it. Because if I can just help one more person not suffer what my family and I have had to suffer from, or to pass away, like these patients that I talk to every day, it's all worth it. It doesn't matter how many hours late into the night, just like all of you are doing as well. We take in our organization, and it's one thing that I personally feel, maybe it's because I'm a patient, but we have to have the research. Research is an absolute huge component, as well as, you know, patient advocacy. Because without that, we're not going to get to what Trish talked about, which is, you know, being able to treat this as a chronic type of situation. I know our organization is very fierce about supporting research, and we seek that out with people who are doing different things. To your point, Trish, not having the same thing done over and over. And we want people to be innovative. We want people going after new things. So we have been very fierce about that. And, we had the opportunity to have a CZI grant, and we now have a scientific advisory board we just put together, and we just started it. And what we did was approach it a little bit differently. When you take a look at some of these other diseases in the world that, obviously not LFS, but learning to approach things very differently, not doing it the same way over and over, like the definition of insanity. It's true. And, not just writing papers and making sure we're actually doing something with that, that we can finally put on a paper. So we actually grouped a whole bunch of scientists from around the world that specialize in P53, not necessarily LFS. And then we have a clinician and one other person on there that does specialize in LFS. We're trying to approach it differently. And it's amazing what 2 phone calls and meetings have already done. So research is absolutely critical. And when I look at what, just taking our youth group, we started a youth program. Dr. Josh was super kind to let us bring, 21 kids down there, like invading your lab. And, the interesting thing about the next generation, which I think is super important, is I always say knowledge is power. So when they saw, your lab, and your lab staff was absolutely so generous and so kind to let us come in and see that, those kids were blown away. And, what's very interesting of those 21 kids, unfortunately, a few have passed away, but, you can't imagine, I think almost all of them, except for maybe 2 or 3, are going into either genetic counseling, research, science, or becoming, MDs. So, you're creating an entire generation when you talk about research and making that available to people. Not only of curiosity, but pure determination. And I think when we do that, you're going to get to that point that Trish is hoping and praying for, like all of us as patients, including Jenny and myself and my children and my sisters, is being able to live with it and live a very long life and thrive with it and do all the sports, like Jenny with hiking, me with horseback riding, Trish and her son doing their thing. So research, it's not an option. It's absolutely necessary. And it's just as important as patient advocacy, because without that, we just won't get anywhere, and everyone will just continue to pass away with LFS. I mean, you'll have a few that'll live and live their whole lives, but without all the things we've just talked about today and having that research, we just got to have it. It's critical.
It's a great point. So before we finish, Jo and Wendy, you've been sitting silently listening to this conversation. Is there anything else you want to add from your perspectives or questions you want to ask the group here?
As always, I learned so much from, listening to you guys. This was wonderful. Thank you so much for sharing so much of your perspective on this. I think, one thing that, came up in, so many of your stories and things were just, how many times you had been told that, this is very rare and, kind of there's no information, and just kind of this message that everyone was kind of winging it in a lot of your care and making decisions. And we certainly still have a long ways to go, but through the work of Dr. Schiffman and others, we have also made progress. And this is rare, but just at Huntsman alone, we follow over 200 people with Li-Fraumeni syndrome. And so, we do have information, and it's both a combination of everyone is unique, but also we can learn from the experiences of other families. And I think that's something that I also hear from other physicians in the community, who are encountering our Li-Fraumeni patients who are like, well, there's no information about this. And I think for the future physicians listening to this discussion, I I don't want you to take from this that we don't know anything about Li-Fraumeni syndrome and that it's incredibly rare. I want, I hope that you take from this that, we are learning, and there are patients out there who are experiencing this. There are physicians who are working on this, and that if you encounter these patients, that it's important to reach out to the specialists who are, who have that information and can give you the most, complete data out there, because these things are improving, all the time. We are learning. These patients are so willing to participate in research, and that's really helping move things forward. So, yeah, I guess I just, really want to emphasize that, this is all a work in progress, and that, what we know right now isn't going to be the same, even, months from now. So, please reach out. Please find people like Dr. Schiffman that you can consult with, and really make sure that you're pulling in all the expertise on this, and not relying on, some blurb in a textbook. We just recently had a new patient who, we were able to find publications on over 40 patients with her specific TP53 mutation, not even just general Li-Fraumeni syndrome, but that specific genetic change. So, it's, there is information out there, and, we certainly want to make sure that people, we use all that's available when we're planning care. And I guess, my other plug is, that Gent counselors are resources, for these patients. I think a lot of the early stories when everyone was talking about how they got their diagnosis of Li-Fraumeni syndrome, and the challenges with getting tested, a lot of barriers to genetic testing are coming down. That technology is becoming much easier, much less expensive, much more available. And so, a lot of the debating and angsting we did about, in the past about whether a family history was strong enough to warrant genetic testing, has really changed. And, just because, you may not be familiar with how to order that test, or it may seem like a difficult thing to get done, doesn't mean that it's not appropriate for that family. And, genetic counselors are a great resource for helping you to get that testing for your patient, and to make sure that, all patients who have any a possible susceptibility to this, do get tested. So those are just a couple of plugs, but, just thank you again to, to Trish, Jenny, and Jen, that your stories were amazing. And just, like I said, I always learn a lot, and you've given me a lot to think about today and going into my week. So thank you.
Thanks, Wendy. Jo, any comments that you wanted to add to that?
I think from the research side, like, I've always thought that, especially like coming into working with the genetics team and with Josh, there is always research to be done, because Jen's right, it's absolutely necessary, and it is slow. I mean, I wish we had a magic crystal ball. We could be like, oh, we'll figure this out in 6 months, or a magic wand that'll speed everything up. I wish that was true. And I think, in all honesty, this pandemic has also taught us that things, it's not always easy to do the research when things pop up and you have to reevaluate. Okay, well, how are we going to collect this information? And, how do we collect this, or how do we do this when times when we can't necessarily do that, and you somewhat have to reevaluate what you're doing or how you're going to do it. And for the med students, I would say, there is a ton of research going on right now. And as Trish pointed out, we have like Huntsman, we're doing the ctDNA study as part of the Edison project. And, we have some things going on with City of Hope, and, we work with David Malkin's group on things, but there's a ton of research going on. And so instead of thinking, oh, how do I create this new project and reinvent the wheel when that project's probably already happening. And and instead of thinking you have to go about it yourself, figure out if that research is already happening, figure out how you can be a part of that. Add your brain power, because the more brains that work on the research, the more power we have, and that's honestly super powerful, and that will actually help maybe move things along a little bit faster and get those results going. And because the research doesn't happen by itself, and it takes a lot of people to do it. And so it is important, and I'm always very grateful because I know I have a purpose for what I do, and that's not a lot of people get to say that. So I'm very lucky for that, and I'm very lucky for the participants, especially all our LFS communities who are so willing to do whatever it takes, filling out paperwork, giving us blood draws, even though that's not always the most fun thing to do. But they're willing to do it because at the end of the day, they want to help, and they want to make it so the next generation and the generation after that has, better outcomes than what they have. So
Thanks, Joe. So I'll just finish up by sort of saying these few comments. One, just so people realize who are watching this, our job was to speak to patients with Li-Fraumeni syndrome and hear their story today, and absolutely we did that. It was very important to me to have Wendy and Joe on this call, because when I think about taking care of patients with Li-Fraumeni syndrome, it's not just the doctor, right? It's the genetic counselor, it's the research, and that's why Joe is here from the clinical study perspective. We all need to work together to make the difference. And the common themes that I really heard in the past hour and a half were that in order to be a good doctor, in order to provide good care to patients with Li-Fraumeni syndrome, first and foremost, you need the knowledge, right? You need to be educated, you need to do your homework, you need to have research. So when the patient comes into your office, you know what you're talking about, right? That's going to provide a lot of comfort and actually going to make for good care. The second is compassion, right? Jen, you kept saying you want to make sure that you can walk in the patient's shoes. So not just know about the disease, but have compassion for your patient. Then we also talked a bit about having passion as well, part of compassion, right? Really care about what you're doing. And I think the most important thing, really, that goes with all of it and wraps it all up is hope, right? And if you have knowledge, if you have compassion, if you have passion, then you're going to provide hope, much needed hope, required hope, hope that there is a chance to make a difference and a chance for patients with Li-Fraumeni syndrome to live a full and wonderful life together. So I think the most important thing as we wrap up is I'd like to go around and have each of you say just one final sentence, anything you want related to Li-Fraumeni syndrome or otherwise. So we can start with Jenny, please.
Well, I'm just thankful for the opportunity to talk to you guys today, and to meet Jen and Trish over this forum too. It's always really makes my heart feel good to hear other people's stories who've gone through something similar. I don't know. I just think, this is a marathon that we're on, and any opportunity to educate the next generation of doctors about it and help in our efforts of educating more people, pushing for more research, advocating for your patients. I'm just really grateful for that opportunity. So thank you. And thank you, Dr. Schiffman, for all the work you're doing. Really appreciate it.
Thanks, Jenny. Trish, any thoughts, comments?
I do want to reiterate her thanks. I really appreciate being able to be part of this, but also I appreciate that you are doing this for the next generation of docs. I think that speaks to your passion and compassion, is putting a face on this, and we appreciate that as patients. And just, for those future docs is that we as patients do want to help and be involved. I know when we did our family camp that, and Joe was there taking blood. I mean, it was like we were lined up with our arms out, right? That any opportunity that you have to involve families and actual patients to help make this syndrome more livable and better, that your patients want to hear about that, and I guarantee that the majority of them will jump at any chance. So don't be afraid to ask for our help, because we will give it gladly.
Fantastic. Thank you, Trish. Jen.
Yeah, so really thank you for giving us the opportunity to be here, because it was awesome. And, being able to have the opportunity to meet everybody and hopefully work together with you in the future. We are very excited about that. And like Trish and Jenny said, we're here to help you as well. And you'll find, I think LFS patients are, they are determined. I will tell you that. We're like sponges. We just want to soak up everything you have, and you'll probably get a million questions. But welcome that, because we really care. And remember, we're not numbers, and we're all individuals with our own stories, and we're here to help. And we just want to live. So thank you again, and we're looking forward to some bright futures with all of you. So thank you.
Excellent. Well, thanks everybody. Have a wonderful, safe, healthy, and hopeful day. Take care.
Bye.
Thank you.
Bye-bye.